Hello, class. Today's lecture is about contrast agents, and this is one of my favorite lectures to do because we already know about contrast agents. It's things that we've already learned and done and practiced in our general radiography career. If you happen to be a nuclear medicine technologist and to start with, then you might not know about contrast agents, but all radiography students know that because it's part of our education. So the question is, why would we even use contrast material? Well, as I teach my general X-ray students and other students, we use contrast to make something appear brighter or more readily than it appeared by itself. Because most of our body structures have about the same density, uh, there many things are hard to see. I use an example of that air is very non-dense, very radio lucent, and bones are radiopaque, so they easily show up as black and white. Everything else has a gray tone, which is why CT is such an advantage to us. But we need to add more contrast, more black and white differences to see something well. So we either have to increase or decrease the density of surrounding structures by adding contrast. So the examples of what contrast looks like. If I look at this image here, obviously this one that says high contrast is much easier to read or see because high contrast just means that there's a short grayscale. You jump from black to white very readily, or from white to black as in the next example. But as you get lower and lower and lower contrast, it becomes more difficult to see. It doesn't mean that the object is not there, it just is not as readily observable. If we do the exact opposite, where you have a light background and a dark and a black letters, again, you have high contrast. You get down here, and that low contrast is very hard to discern. Things begin to look alike. So we've demonstrated here in a simple matter why we use contrast agents. I use this oftentimes when I'm doing a lecture for prospective students or just visiting high school or junior high students to say that all three of these abdominal images have the same structures internally. Yes, if you've been to X-ray school, you can see some outline of the psoas muscle and probably the kidneys here, and you certainly know that that's air in the stomach and in the colon. But the colon really doesn't show up until we obviously give air and some contrast. I'm guessing this is barium, but it could be iodine, but some type of contrast agent. And then obviously we've given iodine here to make the kidneys, the outline of the kidneys, and then the functioning part of the kidneys show up, the ureters and the bladder. I tell them, as usual, as you already know, that all of these structures are contained in here. They are just not visible without contrast. So that's an easy way for me to demonstrate for them about contrast. If we look at it in CT of what you guys are looking at, we can see in the heart here, we can see the ventricular septum here, and we can see the different chambers of the heart. We can see the aorta, and we can even see our little friend, the azygos vein here that shows up. I love that one on cross-sectional anatomy. Here you can still see some of those structures. They are not as evident, especially that azygos vein, and it would be hard to see things inside the aorta without the contrast. Going further along that, looking at a liver with no contrast and contrast, we know that many liver lesions show up with contrast. Most of them show up early on, except with the exception of a hemangioma, which needs a little bit of delayed time to show up. And again, showing the same thing in the brain. So if we look at the history of contrast material, if we say that X-rays are discovered or revealed in 1895, in November of 1895, in 1896 when it was first published, that same year they gave contrast. We used contrast in a guinea pig. It was toxic and the guinea pig died, but we were able to see that you could give something orally and make the digestive system show up. Later on, we used Thorotrast, which was radioactive itself, so it was discontinued because it was giving off radiation itself, but it also was a contrasting agent. Um, in 1910, we started using barium sulfate. Barium sulfate is still barium sulfate, is still barium sulfate. We may mix it with different things, we may have different concentrations, but the agent that is blocking out the x-rays and letting us see the structure is barium sulfate. It was low cost, it was not very toxic, and it was readily available. All those three things are still true. In 1927, we started using iodine, a water-soluble iodine that could be injected, and done many things with, but we start off mostly with injecting. But we know that we can use it to drink and do in the GI tract also. So both of those are positive contrast agents, meaning that they have an increased density. They appear white. On an X-ray are brighter than their surrounding structures. We also use negative contrast agent. I always jokingly tell my students, the first semester students, that they're using a contrast agent all the time. They're using air to fill up the lungs to blow them up, and so that's contrast we're using there. So negative contrast agents are any gas, air being the most common one that is used to that is used on an image, and it makes the image less dense. So use is appears black on the X-ray, and so a negative contrast agent is going to appear black. A positive contrast agent, of which it's barium or iodine, will appear white. Those kind of things you know already. So the two basic classifications are negative, air and other gases, and I've just said those three things there. And the positive contrast agents are barium and iodine, and again, they absorb more X-rays of the surrounding tissue, hence they appear white or light. If we look at the methods of administration, parenteral is injection into a vessel. If you look up the word parenteral in the dictionary, it's going to say other than by mouth. So literally, a nurse could call a parenteral injection if you were doing a TB skin test. But for us in radiography, we're going to say a parenteral injection is into a vessel. Most often, anytime that we do something in CT, it's going to be in a vein, but it could be a parenteral injection, could be into an artery. We're just usually not doing arterial injections in CT. We're usually doing peripheral vascular injections. Ingestion, and that's when we want to see something in the alimentary canal, anywhere from the mouth to the anus. So we can use it for upper GI and small bowel in X-ray, but we also give it certainly when we're doing abdomen exams in CT. So because we want to see the stomach and the small bowel, we can use barium or iodine for that. There are certain preparations for iodine that are just used to drink, but many of our iodinated are the new low osmolar non-ionic contrast agents. Omnipaque being one of them, iohexol, can be used anywhere. So we can use it in ingestion, we can do it retrograde, which is where we're doing an enema, using barium or iodine, and also when we're using down in a cystogram. Both of those are going against the flow, so it's going to be an enema or a cystogram. And then intrathecal, which is what we're talking about when we go in the thecal sac here, we're putting contrast or air into the below into the subarachnoid space. So we're going into that thecal sac, the covering that you might think of it as the meninges over the spinal cord. And so we're doing that when we do a myelogram or post-myelogram. So those are the four ways: parenteral, ingestion, retrograde, and intrathecal. And there may be on any particular iodinated compound that tells you certain things that it can't be used for. In this example, Omnipaque, it has no warnings. It does not have any warnings. Whereas if you go to Visopaque, it says not for intrathecal use. So we couldn't use that for a myelogram or a post-myelogram study or anything in the brain or spinal canal. Hypaque, not for intrathecal use. Isoview, not for intrathecal use. So just because it's iodine, and iodine is used in the thecal sac, not every iodine preparation can be used there. Following that same thought, this is an oral iodine, which if you've done x-rays, I'm an old guy. I've been doing x-rays for more than 40 years. I went to x-ray school in the 70s, but I've tried to stay current. But gastrographin and gastroview were common things that we used. It clearly says not for parenteral use. And this one literally just says do not inject. In other words, these were only for use orally, that would go through the digestive tract. They're not for parenteral use and do not inject it in any way. So these are ones that were used for a particular thing, and yet they're still iodine. I'll go back to my statement. The only iodine could be injected, but not every iodine could be used for everything. And if we get to more of our CT, barium, always oral. always we're going to use barium only when we're doing into the digestive tract. And you might recognize some of these. ReadyCat are some of these that we might use for CT. Obviously, this was a CT preparation. These are some that we might use in just general barium studies. Probably not, we wouldn't use this one in CT because it is very dense, but these are used in other studies of the digestive tract. And as you can see, it usually highlights what they're doing. This one particularly for the esophagus, for the stomach, and then so these are particular, they're always barium. If we look at negative contrast agents, we usually think of those that in CT, it's usually going to be we've inserted some gas and maybe sometimes into the abdomen or into the stomach. So we might use easy gas. If you've done general x-rays before, you've probably used this to do a double contrast where that you give some barium or iodine, but usually more commonly barium in the upper GI tract, and then you give this gas that's something like an Alka-Seltzer or Pop Rocks that makes gas. But we in CT, we might use this a CO2 machine for doing a CT colonoscopy or colonography, whatever you want to call it, where we use the CT and then we have to administer a gas into the colon and fill it up. So the CT machine is done for that. So negative contrast is always going to be some type of gas. It could be room air or it could be CO2 or other things. So if we're talking about intravascular contrast agents, we've already said it has to be iodine. Iodinated agents are universally used because they're water soluble, they're easy to administer intravascularly, and we can do a peripheral vascular, and many times we have the patient that already has the IV started, and in general, they're very safe. Yes, we've all heard stories of someone who had a contrast reaction, but if you take the number of times that iodinated contrast is given to a patient across the world and the number of reactions that we have, it is minusculely small. It's kind of like who in here is afraid to fly in an airplane? But if you look at air traffic, the number of air miles and the number of people that fly, the percentage of people that are killed or harmed in air traffic is so much smaller than any other transportation that we have. It makes me afraid to get on the freeway here in Houston because of so many traffic accidents and deaths that we have here. So they're relatively safe. IV contrast agents increase the differences in attenuation between adjacent structures. We've already said that because different tissues more enhance differently. Obviously, the kidneys enhance different than the liver. Iodinated contrast media is handled differently in normal versus abnormal tissue. If you have an abnormality, it may absorb more of the iodinated contrast or it may absorb less. So the disease process may cause it to absorb more or less, and the organ itself, i.e., the kidney, the liver, the spleen, are going to absorb contrast media differently also. If we talk about iodine, its atomic number is 53. It's less dense than barium. It's an aqueous iodinated compound, and it can be used orally. We can drink it. We can use the intrathecal. We can use it in ducts and joints if you're doing if you're doing an arthrogram or a ductogram. Exam of that might be a hysterosalpingogram, HSG, or even some silograms. I don't know if we still do silograms. There may be a few places that do those. Even though these are not CT exams, we can use iodinated contrast. In CT, we may do a fistula or a tract exam where we're trying to see if there's a blind passageway between two organs or if there's a connection between two organs by that fistula. The fistula is just an abnormal passage or connection between two organs. And we certainly can use it in the vascular to show up any of the arteries or veins. Iodine is excreted via the kidney, which is why that we have to be concerned over kidney disease if we're using iodine. Here's some properties of that iodinated contrast agents. We talk about the word osmolality, and unless you've studied a little bit about contrast, you might not know this term. It literally is the number of particles in solution per unit liquid as compared with blood. So we're taking the osmolality and always comparing it with blood. Does it have more or less particles in solution than the blood does? A high osmolar, in your book does it HOCM, high osmolar contrast media, may have as many as 7 times the osmolality of blood. So it would have 7 times more dissolved particles in it than blood would. than blood would. Well, we know that the body likes an equilibrium. So if I'm putting something very concentrated with something less concentrated, they're going to try to mix and become uh, the same. They're going to become homostatic. We could have a low osmolar contrast media have roughly twice the osmolality of blood. They still have more particles than blood, but not nearly as much more as the high osmolar. So this is going to be much more friendly to us, the low osmolar contrast media. And the isoosmolar agents have the same as blood. I don't actually know any isoosmolar agents. I am familiar with these. All the old iodinated compounds that we had were high osmolar. The newer ones that we have that are non-ionic are also low osmolar. Um, you might see in your book osmolality and osmolarity. Osmolality refers to the number of particles per kilogram of water based on weight, not volume. It's measured as milliosmoles per kilogram of water. Osmolarity, which is what I just said, refers the previous one on the previous slide refers to the number of particles per unit of solution. Europe uses one of these terms. We use the other. The terms, while they're not exactly the same, they both describe osmotic activity, and refers to the number of what I want you to remember. It refers to the number of particles in the blood or extravascular fluid. In our case, we're looking at the blood. So we're going to use those. We're going to use these interchangeably, even though they're not literally the same. We're more likely going to use osmolarity than osmolality. These terms are interchangeable to describe the osmotic activity. So blood would have a number of 300 milliosmoles per kilogram of water per kilogram, whereas a non-ionic would have 6 to 800, and an ionic, the one that might have 7 times, it could have up to 1300 to more, because if we did 3 times 7, that would be 21. Anything more than 1300 uh, would be would be ionic. Our non-ionic then are going to be 6 to 800, up to 200, up to twice as much as blood. So the non-ionic low osmolar are better because they're closer to blood. And we have less reactions from that. So again, we've already talked about the importance of osmolarity or osmolality. Uh, Osmolality or osmolarity is the primary factor in when we have reactions. And I'm not talking about that you're completely positively allergic to iodine and you have an anaphylactic reaction. That is not what I'm talking about. I'm talking about all these other things that people have problems with. And you can actually die from a reaction and not have an anaphylactic reaction. It's an anaphylactoid type reaction, but it's still severe. So osmolality is the primary factor in these reactions. The goal is to reduce the osmolality. How do we do that? Well, we use the low osmolar non-ionic agents because they have a reduced osmolality. So contrast molecules, any contrast agent we use, if it has iodine, on the iodine atom, the molecule has 3 iodine atoms on that molecule. Ionic molecules, if we have an ionic contrast agent, the molecule, when we put it inject it, it dissolves into 2 particles. So it's called a 3-2 ratio. We have the molecule itself, and then it divides into 2 particles, into a positive and a negative, which makes it ionic. Ion just has a charge. That's what it means. Non-ionic molecules stay together. So for each particle, there's 3 atoms of iodine on there, and there's only 1 particle. So a 3-1 ratio is better than a 3-2 because it's less particles. The 2 is telling how many particles in solution. The higher ratio is better, a 3-1. You have the same amount of contrast because we still have the same 3 iodine atoms on this molecule, and we have less reactions because it's low osmolar. Um, I'm just going to kind of just talk through this really quickly and not read each piece of it because you can do that. But anytime that we inject a contrast agent into the blood, we cause a disruption in the osmolality of the blood. When I inject this contrast, whether it's a high or low osmolar contrast agents, then it is more concentrated in the blood, and so the blood is going to try to dilute that. How does it do that? Well, it pulls fluid out of the red blood cells, which makes them shrink and become malformed. That's a problem. And it also pulls in interstitial fluid. All that fluid that's in the tissue, it pulls out and goes into circulation. So then you have a great increase in the volume, the solution volume of the blood. That's good, but then the kidneys start pulling the iodine out, and so that when you get less iodine, then the blood has too much volume, and so then you have the fluid leaving circulation and going back out into the tissue. This happens every time we give contrast. The problem is, and sometimes it can flood the lung tissue with fluid, and then you get uh, the reverse of flow, and you get the flow of the fluid back out of the circulatory system, and then you get fluid in the lungs and also in the tissue. So these shifts may cause problems associated with iodinated contrast agents. Again, this happens a little bit every time we give contrast, but at different times it can be a problem and for different patients. So the properties of the iodinated contrast agents, the ionicity. Ionic agents contain molecules that will form ions in solution. That is the high osmolar old contrast agents. They are ionic. Non-ionic agents contain molecules that do not break down or dissociate. They're the 3-1. They have the three iodine atoms on that one particle, and this one, it still has the three iodine atoms, but it is two particles. Then you break it off into a positive and negative ion. Although most non-ionic, this is from your book, but in general, when I say non-ionic, I'm going to mean low osmolar. And your book points out, although most non-ionic contrast agents also have low osmolality, the terms are not synonymous. Your book says they're not synonymous, but anytime I've seen anybody use them, they are synonymous. So when I say non-ionic, you're going to look, every one of the non-ionics I talk about are going to be low osmolality. So then, ionic versus non-ionic agents. Well, the ionic are high osmolar, as we've said before. They both have iodine. They have the same amount of iodine, the three iodine atoms on that particle have positive, but the thing is different is the ionic have positive and negative ions because an ion is a charged particle. They break the molecule breaks up in solution, and it becomes two particles, which doubles the amount of gives you more particles in the solution. Non-ionic, or the low osmolar, have the same amount of iodine, but they do not break down or dissociate. So you have the higher ratio of three iodine atoms to one particle. This is just a breakdown of it. I don't think anybody's going to ask you this, but if we look at the benzoic ring or the benzene ring, this is showing you a molecule here. Three iodine atoms there. It's space 2, 4, and 6 on this molecule. So iodine here, here, and here, and then the other things are chains that are on top of that. Part that makes up the atom. So uh, 3 and 5 has stability and detoxify, and then there's a cation on spot number 1, salts and sodium meglymines. All of this stuff is important to the chemists, not so much to us. The non-ionic has 3 iodine atoms also, still on the same slots. 2, 4, and 6, but it does, the side chains are on 1, 3, and 5, and they do not break up. So this one stays in together. This one breaks down into 2 particles. That's just showing you the chemical makeup of it. What is important to us, and what I want you to remember, this is vitally important, could be on my test, is on my test, and the registry likes you to know about these. What it talks about is common ionic high osmolar contrast agents. Contrast agent. What we don't want to give for the answer, and the registry will not use these as your answer, are the brand names: Hypaque, Renograph, and Renovue, Conray that we see on there. Those are the brand names. This is the contrasting agent within there. Diotriazate is what's in Hypaque and Renograph. Iodamide is in what's in Renovue. Iothalamate is Conray. All of these are iodine, but it's the type, the way that the contrast agent is put together. This is with the iodine and all the side chains and everything. So it's different brands and they act a little bit differently. Um, RenoView can be injected. Hypake and Renographic can both be injected. Hypake can be drunk. But what I want to point out is these are high osmolar ionic. Note that all of them end with E. All of them end with E. This is how I remembered it. If we have the common non-ionic low osmolar contrast agents, again, this is the brand name. I've talked about Omnipake because that is used in most of the clinics where I have students. I'm not saying it's universally used, but it can be used for anything. So uh, Iodexanol is Visipake, iohexol is Omnipake, iopamidol is Isoview, and ioversol is Optiray. All of these are low osmolar non-ionic. Note, they all end in O. So I would lose that as my clue that if I couldn't remember these names. Uh, important to know these, not the brand names. Not the brand names. So you want to know what these are because any testing, they're going to use those names. Viscosity is just telling you how thick something is at room temperature. Every fluid has an inherent viscosity. You know that at room temperature that water has a different stickiness or thickness than honey because those are both at room temperature. But so it's the resistance to flow or how sticky it is. High viscosity means that's thick or syrupy. Low viscosity means thin or watery. And they're inversely proportional to temperature. Temperature goes up, viscosity goes down. Temperature goes down, viscosity goes up. Um, Viscosity is determined by the particles in solution and the attraction between these particles. Again, every fluid has an inherent viscosity. We can change it by changing the temperature. The concentration of iodine is uh, is how much iodine is in a given volume. How much we can have 10 we can have 10 mLs of a solution, but it could have a different concentration, a different amount of iodine in that solution. The higher concentrations, the greater the opacity because it has more iodine. Concentration is expressed as weight per volume. How many grams or milligrams of iodine are in this uh, uh, how many grams per milliliters or how many milligrams per milliliters. It's almost always expressed in milligrams. How many milligrams per milliliter or how many grams. So it's the amount, it's the weight, is weight per volume. The grams are a weight and the ml is volume. So if we look at this, how would we figure out how much iodine a person's getting? So how many grams of iodine will be delivered when 100 ml, think of a 250 ml cc syringe or a 100 ml syringe, and we're using an agent with 320 milligrams of iodine per ml. Well, that's pretty simple. If we have 320 per ml and we have 100 mLs, we're merely going to multiply 100 times 320. And so that would come out to what? If you add zeros, 32,000 milligrams. I don't have 32,000 milligrams as an answer, do I? But if you divide by 1,000, that would come out to 32 grams of iodine. So that's how much iodine this person would be getting if we were using a contrast agent that has 300 milligrams per milliliter and we gave 100 milliliters. And we can see that here, 32 grams of iodine. So be careful when you're looking at it if the answer is given in grams or milligrams. So 100 times 320, 32,000 milligrams of iodine. And so if we wanted to convert milligrams to grams, we would just divide by 1,000. And so we got 32 grams of iodine. We're more concerned with pediatrics and usually with elderly people, with the geriatric patients. They seem to be more sensitive to many things. So the pediatric dose is most often based on the weight of an infant or a child. And again, be careful because we usually use in the United States we usually use pounds, but in other places they use kilograms. So be careful when you're looking at that you're looking at pounds or kilograms because there's 2.2 pounds per kilogram. So if a kid weighs 10 kilograms, then they would be somewhere about 24 pounds, as opposed to if they were 10 pounds. So be careful that you're looking if you're using pounds or kilograms. The adult dose, typically we use a uniform dose. If you've been doing CT for a little bit, or when you start, you're going to see that your facility may have a dose chart that they say any adult weighing over 100 pounds. For this exam, we will use 50, 75, or 100 mLs of contrast. Now you have to look at the concentration of the contrast you're using, but they're usually not widely different, and they would be specified in your protocol. So adult dose, typically a uniform dose for each protocol. However, weight-based dosing for adults has advantages if the adult is sensitive and you want to be sure that you don't overdose them with contrast. Two other terms that we might talk about is miscibility. That just it refers to the ability of the contrast to mix with blood and other products and not produce an emboli, or not produce uh, not interact and cause problems. So it's how well it plays well with others. The toxicity just says is I mean how poisonous it is. And so we our contrast agents have a low toxicity, but we do know that they have a toxicity. In larger amounts they can cause problems. They can become poisonous or toxic. The clearance of iodinated agents are not metabolized. In other words, the body does not take them up and break them down and convert them into something else. They do not metabolize them. They're excreted via the kidneys. Almost universally, they're excreted through the kidneys. Basically, we would say this is a generalization, that the half-life in patients with normal renal function is approximately 2 hours. In other words, within 2 hours, a patient is going to have eliminated at least half of the contrast agents. That is somebody with normal kidney function. We know that kidney function goes from very poor function to very high function, which is why we worry about the elderly and the infants, because sometimes their kidney function is a little bit different. Pregnancy, well, we try not to do CT exams on patients that are pregnant. In some cases, that may be the only way we can get the exam, and so the good has to outweigh the bad. We don't have any proof that contrast agents pose a particular risk to the unborn fetus, but we can't do testing on that. I don't think we can ask a pregnant woman to say, "Oh, will you volunteer to let us do a test on you to see if the contrast is going to hurt your fetus?" Well, that would be unethical and illegal. So, but just from incidental evidence from having done CTs on pregnant patients, there's no evidence to show that it has a particular risk, because we know that occasionally we do have to do exams and maybe give contrast to pregnant patients. We would like to avoid that, but we try to avoid doing a CT on a pregnant patient anyway. Lactation, again, we know that a little bit of the contrast agent can get into the breast milk, but again, there is no reason to think that at normal levels that the contrast agent is not safe for a nursing mother. So we don't really have any precautions on that. If we look at some of the drugs and contrast media that we use, uh, there are some common drugs there are many drugs that are incompatible with contrast media. When I was doing first doing CT, we didn't flush with saline. We did not chart how much contrast we used. That's incredible to think about. That was in the late 80s. That it was amazing how the things we didn't do. We wouldn't think about that now. But if you give contrast media with some drugs, it can cause suspensions, little snowflakes or little things, little particles floating in there. It can cause precipitates. It can cause things that fall out, like rain dropping. It causes things that settle out, and it can also cause an oily solution. I don't know the particular drugs that this happens with, but that is why we always flush an indwelling catheter. Well, if we start a catheter, if we start an IV ourselves, we inject with saline first to be sure that we've got a good injection, because the saline's not going to bother the tissue that it goes out into, because basically saline is the same as interstitial fluid, whereas iodinated contrast that gets out of the tissue can cause a problem. It can cause skin breakdown, it can cause tissue breakdown, and a problem. And plus, on top of that, it hurts. So always flush lines with saline before and after contrast injection. We want to be sure that there's no other medications in the line that the contrast will interfere with, or we want to be sure that we've got a good injection and the contrast is not leaking out and burning. We talk about side effects. While they are rare, adverse reactions can occur. We can't always predict. There are certain bits of the population that we might think are more likely to have a reaction, but that is not universal. That is not always true. So we can think for sure this person might have a reaction and they don't, and then we can think this person seems totally clear and they could have a reaction. So it's impossible to predict which patients will have an adverse reaction to IV contrast media, but we can have some guidelines of people that might be. So we need to be able to quick to respond to any reaction that we have. If we talk about the how we divide these up, chemotoxic, they're hemodynamic. Hemo obviously dealing with blood, and dynamic meaning movement or change. So it's the chemotoxic is talking about how we get changes in the blood when we give contrast. Well, obviously the type of contrast we give makes a difference. We've already said that high osmolar ionic is worse and causes more change than the low osmolar. The amount of contrast, well, obviously, if I give a little bit of contrast, wouldn't cause as much problems as a lot of contrast. And then how fast I give the injection. Think about if you drink something really rapidly, it can cause you to have problems. And if you drink it more slowly, the same thing. But there are times when we need to give the contrast rapidly. So we have to weigh the benefits and the pluses and the minuses. But so the type of contrast, the amount of contrast, and the speed of injection can all make a difference in how that contrast reacts in the blood. Idiosyncratic are reactions that we just don't know why they happen. Again, that hemodynamic, we know that all those, if we do all those different things, that it can. We already know how this works. Idiosyncratic, we don't know. Unknown reason. They may or may not be caused by the contrast properties. They could be caused by the anxiety or a certain thing that's going on with the patient. They have the reaction when we give it to them, but it may not be really directly related to the contrast media, which is why we call it idiosyncratic, which means unknown reasons. Individual patients have differences. Sometimes we get sick when we smell some things, sometimes we don't. It's according to our own mental, physical, and emotional state. And any of those can play a part: your physical, your mental, and your emotional. Have any of you ever had something that made you sick, and just the thought of it again made you sick? The object didn't have to be there. I can think of several things. I got sick on chili once, and just the smell of chili made me feel nauseated for a long time. So that is more an emotional thing than actual physical thing, and yet I was sick. In practice, it can be difficult to tell the difference between one reaction group and the other. So we have to be ready. Um, the mechanism by which idiosyncratic reactions occur are not precisely understood. I mean, we can physical, emotional, and mental. Symptoms of idiosyncratic reactions resemble allergic reactions or anaphylactic. Again, an anaphylactic reaction, a true anaphylactic reaction, is a reaction that happens when the body has been exposed to something, a foreign material that it does not like, and then the next time it sees it, it overreacts. That is what an anaphylactic reaction is. But we have other reactions that resemble that and have the same symptoms, and so sometimes it's hard to characterize one. Is it a true anaphylactic reaction, or is it just an idiosyncratic? Either way, um, often called allergic-like or anaphylactic reactions, we have to be ready for both of those. Even though it is not completely accurate, the term contrast allergy remains in common use, even though they may not be truly anaphylactically allergic to the contrast agent. The reaction can still be valid and severe. Acute idiosyncratic reactions are usually classified as mild. A lot of people get a little bit of itching on their hand or maybe on their neck. Some people feel like they need to go urinate or defecate. Some people feel a little bit nauseated. Plus, some people say they have a little taste in their mouth. All of those may be just mild reactions. They're self-limiting, of short duration. That is not unusual. Almost everybody is going to have a little bit of that because of that hemodynamic effect, because of the amount of contrast going in the blood body, how fast it goes in, the concentration, all those things. We can also have a moderate reaction, not immediately life-threatening, but the problem with that is it may progress very quickly to threatening. Possible reactions on those might be a little bit of more of a itching on the tongue or the mouth, and maybe the lips swelling a little bit or the hands itching severely. Uh, Possible medications that we're going to give for that really is diphenhydramine. What's diphenhydramine? We would call that Benadryl. But again, medications in testing purposes and on this are going to be listed as their chemical name, diphenhydramine. In severe cases, we would give epinephrine, but epinephrine's really more for this. So the first line of reaction is going to be diphenhydramine or something of that aspect. So moderate. Severe reactions potentially are immediately life-threatening. They may go into cardiac arrest, a bronchial spasm, where they can't breathe, or they stop, the heart stops beating. This is going to require oxygen and medical intervention. We're going to have to intervene if they go to this. So this is life-threatening. This is not life-threatening, but concerning. This is you just want to comfort and be with the patient. Some risk factors that would make us believe that this person might have this reaction if they've had a previous contrast media reaction. Again, always we're worried if they've had that before, because whether it, no matter how it is, if they've had it before, they are in a higher category to have it again. Anyone with asthma, many things can elicit an asthma attack from people, from pollen to dust to just everything. So there are more hypersensitive if the person has asthma. A history to any food or drugs or other substances may put them in a higher category to be allergic to have a reaction, whether it is an anaphylactic or just an idiosyncratic. People that are allergic to one thing are allergic to many things. Seafood allergies pose no particular risk. Now, you could be allergic to seafood. It is not the iodine that people are allergic to, it's a protein. But if they're allergic to seafood, that may actually put them in a higher category because they're allergic to something. There are certain diseases that are contraindicated. I talked to my students about contraindications, just my general x-ray student. That means don't do it. It's or check farther before you do it. So these are four things that are contraindicated. You should get clarification from someone else if your patient has these. As I tell the students all the time, yes, doctors and nurses should know this, but just because they haven't done their job and they make a mistake and order this when this person has these diseases, it is our job to know that these are some that are contraindicated. One of these was on my registry, and I didn't know what it was. Pheochromocytoma. That's cell tumors of the sympathetic nervous system, usually in the adrenal glands. They help regulate blood pressure. Multiple myeloma. I worked at a cancer hospital, so I knew about that. It was a neoplastic condition that destroys the bone. Myasthenia gravis, not so familiar with that. Autoimmune neuromuscular disease. I had a friend that was telling me about her friend that has that just recently. Our sickle cell anemia, quite common because of we see that in the black population and also certain populations from the Middle East. It's a genetic mutation in the red blood cells. So that is one that we would probably see more commonly than these. All of these are contraindicated to give an iodinated contrast medium. Yes, sometimes we do, but we want to check further to see if they really have to have that exam or do we need to pre-medicate. For patients identified as being at increased risk of contrast media, we can perform examination without contrast media. We're certainly going to use the low osmolar non-ionic, and we might pre-treat the patient with certain types of steroids and drugs to make to lessen the effects or to make to prevent them from having these or to try to prevent them from having these. So we're not saying we're not going to do it, but we want to look at alternative ways of doing it. Um, the chemotoxic reactions, the type of chemotoxic reactions to contrast media are variable, and the underlying causes it can be from many factors. We can get contrast media induced nephropathy. That nephropathy. That is damage to the kidneys. We can have an effect on the thyroid. We certainly can have an effect on breathing. We can have cause pulmonary edema. Uh, we can cause bronchial spasms. Pheochromocytoma, we just talked about that one, which can affect the blood pressure. Central nervous system effects, contrast media crossing the blood-brain barrier can cause seizures. We can have delayed reactions, but most reactions are going to happen within the first 5 minutes. I think the percentage is about 90% will happen within the first 5 minutes, and most of them happen within the first minute. So the systems affected by contrast media: neurological, seizures; respiratory, difficulty breathing and fluid on the lungs; cardiovascular, literally the heart stop beating or beating irregularly; gastrointestinal, vomiting or diarrhea; renal, causing damage to the kidneys; cutaneous, the skin, causing ulceration and blistering in the worst effects, but certainly itching and hives in the lesser effects. So all these systems can be affected. If when we talk about the contrast-induced nephropathy, if a person has kidney disease or low kidney function, we would want to think seriously about not giving iodinated contrast media because we don't know where they are on that scale. Yes, we know that we're going to do blood work as we will talk about, as we have talked about or will talk about in the patient care. You want to know their BUN and creatinine, and that gives us a good idea of the kidney function. But if I had low kidney function, I would not want to have contrast media because I want those kidneys to keep working, not go on dialysis. So in most cases, the effects are confined to a short period of kidney dysfunction that does not produce symptoms and generally goes undetected. Yes, we put stress on our kidney every time that we give contrast media, but if a healthy kidney, the stress is going to be very transient and will go back to normal. In some cases, contrast media can result in significant nephrotoxic effects, particularly in patients considered at high risk for nephropathy, which would be patients that have known kidney disease or have abnormal kidney function tests. So we want to, that's the reason we do the BUN and creatinine and the glomerular filtration rate on a patient before we give them iodine. If we talk about a patient that's on dialysis, if a patient is on dialysis, on scheduled dialysis, then it is safe to use contrast media because you're going to dialyze the patient. Their kidneys are already non-functioning, so you're not really worried about the function of the kidneys. You're going to dialyze the patient. They're going to go on dialysis, and it will act as the kidney and take the iodine out. So do not give contrast media to patients to whom it is hoped that dialysis is temporary. If you're a kidney patient that is just very temporarily on dialysis. I've had two friends. One of them had a heart attack. One of them just for no known reason, a drug reaction. They put him on dialysis for a short period of time. We wouldn't want to give contrast for them because we hope that their kidneys are going to become functioning again. But it's for the people that are on permanent dialysis, end-stage renal function, patients on dialysis who undergo contrast-enhanced CT may continue to use their routine dialysis schedule because it will be removed. So in summarizing that again, if a person is on dialysis that is temporary or and hopes that their kidneys are going to start refunctioning, you do not want to give contrast. A patient that is end-stage renal disease on dialysis, you can give them iodine because they will be cleared later on with their dialysis. Effects on the thyroid. Well, we don't want to give iodinated contrast if we know a patient has a nuclear medicine thyroid study schedule because we will flood the thyroid with iodine and it will not be able to pick up the radioactive iodine. So that would be something you would know in scheduling. It's not that you're causing damage, it's just that you're ruining the schedule, the exam for another imaging modality. So no effects on patients with normal thyroid function. It just means that the thyroid may pick up that and then it won't pick up the nuclear medicine iodinated compounds if they're having a nuclear medicine study. Insignificant effects on patients with hypothyroidism. So it's not as dangerous for somebody that has low thyroid function. When given to patients with hyperthyroidism, you can cause a thyroid storm. So you would want to know if they have thyroid issues and if they're hyperthyroidism. So this can be a life-threatening effect. So you would want to know if they're on any type of thyroid medication or if they have thyroid disease. Pulmonary effects, we've already said it could be bronchospasm, pulmonary artery hypertension, and pulmonary edema. Those all can be effective. Patients at increased risk of those are a history of pulmonary hypertension, or if they have bronchial asthma or heart failure, they could fall into this category. So again, the use of low osmolar significantly reduces this risk. In fact, almost everybody now exclusively uses the low osmolar non-ionic because we know that they are in generally safer. So if you're going to a legal case and you were before a jury and that lawyer said, so you know that low osmolar and non-ionic contrast agents are better, but you chose to give another one because it was a little cheaper, do you think the jury's going to see your way or somebody else's way? Yes, they're going to say, you should have known that you could have given this, or the doctor or the hospital. So almost exclusively, we use low osmolar non-ionic contrast agents. Central nervous system, already said that we could have a problem there. Contrast media has been shown to elicit seizures in patients that have a disruption in the blood-brain barrier. I won't get into that. We'll talk about that in the neuro part a little bit, but that just means that usually things in the brain stay in circulation. They don't just go out into the tissue. Foreign particles, yes, glucose and oxygen does because every cell has to have those. But most things in circulation in the arteries and vessels of the brain have a blood-brain barrier that keeps things in circulation. But if there's a break in that by having a tumor or other things, you can get seizures can be produced from the contrast media. We might give diazepam, which is Valium, or something else to control the seizures. Vasovagal reaction. This is important because the vasovagal reaction is a reaction that's usually if we have go into shock, our blood pressure falls and our pulse rate goes up. Blood pressure falls, pulse rate goes up. In a vasovagal reaction, we get a drop in blood pressure and a drop in heart rate. Um, yes, the person is still going to be faint, but the deal is the treatment is different, what you give that person. So reactions of the vascular system to stimulation of the vagus nerve, that's what this is. The vagus nerve is one of the cranial nerves, and it runs along the thoracic cavity near our esophagus. And sometimes pressure on the esophagus can elicit a vasovagal reaction. It can be emotional. It can be several things that the vasovagal reaction. What I want you to know, it has a drop in blood pressure and a drop in heart rate. Usually in most shock, the heart rate goes up and the blood pressure goes down. Treatment for this is atropine sulfate, important. Well, we've kind of gone over these already. What are some risk factors for contrast media? If I've had a contrast media reaction before, if I have asthma, you know what? I'm not going over these. You can read these yourself. These are all things that could cause a problem. We haven't talked about this, the metformin medications for diabetes. These might also be called Metformin, Glucophage, Glucovance, Metaglip. All of these are types of metformin. We should discontinue use for 48 hours after we've given the IV contrast. Now, a person is going to check with their own physician or their own doctors, but this is the advice that we would go on now. It is recommended to have a BUN and a creatinine evaluation before resumption of the medication. That usually doesn't happen, and we can't enforce that, but we can tell the patient if there's concern that their doctor may want a BUN and creatinine before they start back. I think most times that they just tell the patient to not do these medications for 48 hours post IV contrast. Again, that would be up to the patient and their doctor, but that is the current recommendation, the 48 hours post IV contrast before they start it. These are some drugs that you should know that some commonly used drugs. Diphenhydramine, which we would call Benadryl, is for hives and itching. Epinephrine, which we might call adrenaline, for bronchospasm, where your bronchi close up, or facial edema. Aminophylline for bronchospasm and pulmonary edema. These can be both used. Atropine sulfate, we just said that for a vagal reaction where you have hypotension and bradycardia. Diazepam, which is Valium, that would be for seizures, and furosemide for acute pulmonary edema, congestive heart failure, and hypertension. What that is might be, what is uh, uh, a diuretic. I can't think of the common name for that, but furosemide is a diuretic that gets rid of excess fluid. Some other drugs that we might want to know about are vasoconstrictors. They literally say what they do. They constrict the vessels, which causes a raise in blood pressure. If you're in shock and you need to raise the blood pressure, you're going to may give some type of vasoconstrictor. Epinephrine, vasopressin, or dopamine, all are vasoconstrictors. Some vasodilators, they do just the opposite. They open up the blood flow and make it increased. They're used to increase blood flow, especially to the heart muscles. Maybe some of you have relatives or friends or know someone that takes the little nitroglycerin tablet. They put them under their tongue. If they have chest pains, it can reduce the chest pain because it increases the flow of blood in the coronary arteries. And there's two others after that. I'm not as familiar with these as I am nitroglycerin, but they dilate the vessels. Emergency drugs, oxygen, we know that we have to give if somebody is going into cardiac arrest or other things because we need to increase their O2. Sodium bicarbonate reduces acidosis. We're not going to give any of these. Someone else is going to be giving them, but I want you to be familiar with them. Epinephrine raises the blood pressure and dilates the bronchus, as we saw before. Atropine increases the heart rate because in that vasovagal reaction, the heart rate drops, as does the blood pressure, so we got to get that heart rate up. And lidocaine for ventricular tachycardia and fibrillation. Lidocaine can stop the heart, but it also can shock the heart back into beating if you're in tachycardia, or to put it back in rhythm. So we've talked a lot about that. The mostly this chapter is on injectable contrast because that's the ones we worry about the most. But gastrointestinal contrast media, we use that also. We know that we were doing abdominal and pelvic studies that many times we want them to have oral contrast also. That may not be true in an emergency situation because we are not looking for as discrete of things. We're looking for any major damage. But on a follow-up, we are many times going to give oral contrast. So in the GI tract, contrast media is essential to distinguish loops of bowel from cysts or obstructions, abscesses, or new growth. So we need to give something to delineate or outline those small intestines or large intestine. Oral contrast media is used for most CT studies of the abdomen and pelvis. We may give rectal contrast if we're particularly interested in the rectum and the sigmoid, and you want to fill it up completely. I did this quite commonly at MD Anderson, which is the cancer hospital here in Houston. We gave rectal contrast quite often. We can use iodinated contrast for oral administration. The iodine, ionic or non-ionic, can be used. Again, a non-ionic is more commonly used, but we still could use ionic. 2 to 5% solution is commonly used. I looked up some of the dilution factors on that Omnipaque today when I was talking to my students, and it gave dilution factors. So it's about a 2 to 5% concentration of the iodinated contrast agent. The volume is going to be similar to what we use for barium. If we would normally give 500 mLs of the barium solution or 200 mLs, we would still give the same volume, but it would be at a concentration of 2 to 5%. Oral iodinated contrast agents tend to move more quickly through the body. They're more rapid transit, and they also can dehydrate the patient. They pull in fluid. They pull in interstitial fluid into the system, so that might also make you be more likely to have a little diarrhea. Barium, we talked a little bit about earlier. Its atomic number is 56. It's more dense than iodine. It's an inert powder. That just means it doesn't react in the body. It's just a powder. It's a suspension, not soluble. It does not dissolve into different things. It is just suspended. Think of putting sand in water. You shake it up. Yes, you see the sand floating, and in a little while it goes to the bottom. The same thing. It's a suspension. It does not dissolve. Suspending agents prevent flocculation. That just means of it grouping together. We use different agents in the barium that we give to drink. It may be a little bit thick. It keeps those particles more suspended so that they don't settle out. But we're still going to always shake it well before we give it to them so that it's mixed up in the solution. We can use barium. we use barium only for GI studies of the abdomen and pelvis. And we may use iodine if we have, well, I think that's on my next slide. Contraindications, if there's a perforation is expected or a tear, or they've had surgery on the stomach, esophagus, or if we know that there's a severe blockage. We do not want to give barium because it's much harder to get out. So if there's a blockage, if there's any kind of cuts, tears, perforations in the digestive tract, whether post-op or if they've done any kind of surgeries for reconnecting, then you do not want to give barium because it gets out of the if it leaks out into the body cavity, it is almost impossible to remove, whereas the iodine will be absorbed. Post-exam, we need to hydrate because, again, that can cause people to have some constipation. Is the barium sometimes kind of wants to stay into the digestive tract, especially if the person has a little bit of trouble with constipation. Oral solutions, barium sulfate, a 1 to 3 solution formulated to resist settling. Again, we're going to talk about this more extensively when we talk about the exams themselves, when we talk about the abdominal scans. 500 mLs are given about 45 minutes 45 minutes to an hour prior to the exam to the GI system. That's to let it start going through the stomach and get into the small intestines. An additional 200 mLs may be given just prior to scanning so that the stomach is full. Again, we don't use as dense a solution in CT as we do in general X-ray because it will cause streaking and artifacts if the barium sulfate solution is more dense. It's a slower concentration because barium has more, it is a higher atomic number, and so it blocks X-rays more than iodine. So we use a lower percentage solution. Your book says that water can sometimes be used in the place of a positive agent. That is true, but we would see that more often in a pediatric for something that we just needed to extend or extend the bowel. It's absorbed rapidly and goes through the body. It doesn't do a very good job. But yes, if you just needed something to fill the bowel or the stomach, you could use water, but it is a poor substitute. Air and carbon dioxide, we've talked about that a little bit before, produces a very high negative contrast because air or carbon dioxide is going to make gas in the stomach. It can be administered rectally. If we're doing a colonography or colonoscopy, not colonoscopy, colonography or colonography, particularly useful in CT colonography, where we give contrast air and contrast material air into the bowel so that it shows up. Both room air and CO2 provide reliable colonic distension. CO2 is better tolerated by most patients. So we can use air, and then there might be some occasions where we want to put air in the stomach also to make it distend so that it's outlined better when we're doing a CT for some occasion. So air or carbon dioxide can be used in the digestive system. Intrathecal contrast agents. Intrathecal is when we put something in the canal. Let me rephrase that. Intrathecal means if we're putting something, and I can't get the word meninges out of my mouth, and the meninges, the covering of the brain and the spinal cord. So intrathecal is when we're putting something below the meninges to go in the circulation of the CSF. That's the best way to say it. It's in circulation with the cerebral spinal fluid. Certain iodinated contrast agents can be injected into the intrathecal sac surrounding the spinal cord. That's going to be in the subarachnoid space where the CSF is. But you have to be careful. Every iodine is not made to do that. It will have a precaution on there that says not for intrathecal use or not for injection. Again, our old friend Omnipaque can be used anywhere, that iohexol. Seldom is the contrast agent injected while the patient is in the CT department. Most often we're going to get these patients that have had a myelogram and we're going to be doing a CT post-myelogram. So usually we're not going to do the intrathecal contrast media injection. I guess you could, but usually that's done in the radiology department under fluoro. Patients are usually sent to CT department for a post-CT myelogram while the contrast agent is still in the intrathecal space. We're going to keep the patient's head slightly elevated because we usually want to keep it into the spinal canal. And so if we get them Trendelenburg, it will let the contrast get there and we won't see it where we want to. Roll the patient, make a complete 360, rolling the patient so that the contrast media is mixed and it surrounds the spinal cord completely, not just settling out on the posterior surface or the anterior surface, however you have the patient lying. What is our responsibility as a technologist? We should we should have a complete history, either obtained it or be able to see a history of our patient of anything, any problems they have, any contrast reactions that they've had before. We need to educate our patient if that is possible. If we get a patient that can hear, see, understand, again, working in some trauma areas, that's not possible. But you're going to be in different areas. Usually in the trauma area, someone has done more looking at things than you have to. If you're an outpatient, it may be your job to get the complete history and to explain to the patient. Well, we should explain to every patient who can understand what we're going to do and what we hope to obtain for that. If we're giving iodinated contrast, we need laboratory values for the BUN and creatinine. If we're doing a biopsy, then we're going to need to know the clotting factors, the PT, the PTT, the INR, and also maybe the platelet count. We need to have a doctor available. You should not be given iodinated contrast materials if there is not a doctor available. A doctor or someone, a nurse practitioner, someone higher than you that can order and give medications. Never leave the patient unattended. Well, yes, we go back to our control panel, but we should not leave the department. That goes without saying. We all have to be CPR registered, so if that, in the case that disaster does happen, that we would know how to initiate CPR. And we should ensure the availability of a drug or a crash cart or an emergency cart. We should know where that is in our department or how to access it.